Welcome to the Deep Dive. Today, we're taking a long, hard look at the shifting terrain of heart health. We've got the new 2025 Clinical Practice Guideline update from the American Association of Clinical Endocrinology, that's AACE, and it really forces us to ask, are statins enough anymore?
This is such a cornerstone issue in medicine, and the stakes, well, they could not be higher. We're talking about dyslipidemia, abnormal cholesterol, and triglycerides, which is this silent fundamental engine driving atherosclerotic cardiovascular disease, or ASCVD.
And the numbers are just staggering.
They are. You hear them all the time, but they bear repeating. ASCVD accounts for roughly 1 in every 3 deaths in the U.S.
1 in 3. So for you, our listener, our mission today is to cut through all that complexity. We want to give you a complete high-speed synthesis of how the whole paradigm is changing beyond just statin therapy. We're focusing on the newest and, often very expensive non-statin drugs, their mechanisms, and most critically, the certainty of the evidence.
Well, the lack of it.
Or the lack thereof, exactly. Does it actually save lives?
And that's the key. When clinicians look at your lipid panel, we're zeroing in on high LDL cholesterol, high triglycerides, or, low HDL. But the core message from ACE is that the goal is never just to hit some number on a lab report. The real goal is achieving patient-important outcomes, reducing death, preventing heart attacks, MIs, and preventing strokes.
Okay, but there is one number that's an immediate crisis, right?
Yes. We have to flag this. Triglyceride levels at or above 500 milli-GDL. That puts a patient at severe and immediate risk of acute pancreatitis. That's a medical emergency.
A true crisis level. So let's talk about the underlying mechanism of ASCVD itself, because the sources really hammer this home. It's not just a plumbing problem, is it? It's not just pipes clogging up.
That's exactly right. For decades, we simplified it as clogging pipes, but the modern understanding is that at its core, it's an inflammatory disease.
An inflammatory disease. Okay, let's unpack that, because it explains why some of these drugs work. Where does it all start?
It starts at the endothelium. Think of the inside of your artery as this perfectly smooth, non-stick surface. But when risk factors like high blood pressure or smoking or diabetes come into play, they damage that surface. They create little nicks and tears.
And that's the opening.
That is the opening. Once it's damaged, LDL particles circulating in the blood can get through that barrier and penetrate the wall.
And once that LDL is trapped inside the artery wall, it changes somehow.
It does. It becomes oxidized. Essentially, the LDL goes rancid. The body then sees this oxidized LDL as a foreign invasion. It's not supposed to be there. So the immune system sends in the cleanup crew, macrophages.
Okay.
These macrophages arrive, and they try to clear out the oxidized lipids, and they just gorge themselves on them. They eat so much that they physically transform into these massive lipid-filled blobs we call foam cells.
A foam cell. And that's where the trouble really starts, isn't it?
It is. Because as these foam cells pile up and eventually die, they release a whole host of inflammatory signal cytokines, and that kicks off a huge local inflammatory response. This forms a soft, highly unstable fatty streak, a plaque, and the key word there is unstable.
And that instability leads to the rupture. That's the disaster cascade itself.
Absolutely. When that unstable plaque breaks open, it instantly exposes this highly clot-forming material to the blood. That triggers a massive, inappropriate blood clot, a thrombosis. That clot is what immediately blocks the blood supply, causing either a heart attack or an ischemic stroke. It's the inflammation that lights the fuse.
That makes so much more sense. So if LDL is the vandal, the sources are clear that HDL, high-density lipoprotein, is supposed to be the hero trying to clean up the mess. But we have to acknowledge that the trials aimed at just raising HDL have pretty consistently failed to reduce mortality. So what's its real job?
Its main function is something called cholesterol efflux. It's literally pulling that excess cholesterol out of the artery wall and hauling it back to the liver for safe disposal. But it's also a multi-tool. It has potent anti-inflammatory, antioxidant, and antithrombotic properties. The failure of those trials probably suggests we misunderstand the quality of HDL, not just the quantity.
A fascinating point. Maybe for another deep dive. But before we get to the therapies, let's just ground ourselves in the key numbers ACE wants us to remember.
The targets are absolute.
Okay.
We want optimal LDL cholesterol below 100 milli-GDL. If you're over 190, that's considered very high risk. For triglycerides, normal is under 150. And crucially, remember that critical pancreatitis risk line is 500 milli-GDL. And total cholesterol after a fast should be under 200.
Right. Okay, so that brings us to the bedrock of management, part 2, the cornerstone. And the sources are non-negotiable here. Therapeutic lifestyle changes, diet, exercise, they have to be implemented in all patients.
In all patients. No drug can outrun a poor lifestyle. But for many people, especially those with genetic conditions like familial hypercholesterolemia, lifestyle changes alone are not enough. They always require drug therapy. And that is why statins are still the undisputed foundation.
Just to quickly remind everyone, who are the big groups that absolutely need to be on a statin?
AACE sticks to the four main statin benefit groups. First, anyone with established clinical ASCVD. Second, patients with that really high LDL, over 190. Third, patients between 40 and 75 with diabetes and an LDL between 70 and 189. And finally, anyone in that same age range with a calculated 10-year risk of over 7.5%. Statins are just the most cost-effective, best-studied tool we have.
Okay, now let's talk targets. The ACE task force is conditionally suggesting we push the LDL goal pretty aggressively, right? To less than 70 milli-GDL for high-risk folks.
That sub-70 target is really the focus for secondary prevention. The data suggests that getting to that lower goal probably results in a moderate decrease in MIs. We're talking about 12 fewer heart attacks per 1,000 participants compared to a higher target. And that's a clinically meaningful benefit.
But there's a big caveat here. The sources immediately bring up the law of diminishing returns, don't they?
They do. I mean,
Yeah.
if 70 is good, is 55 even better? And the honest answer is we don't know. Current trial data just isn't sufficient to say if lowering LDL even further provides any additional reduction in cardiovascular death or if it's cost-effective or safe in the very long term.
So the goal is to hit that 70 mark, but not necessarily chase numbers lower than that without a really good reason.
Exactly.
Okay, so if statins are the cornerstone, what happens when a patient, even on the highest dose of a statin they can tolerate, still can't get to that sub-70 goal? That's where we enter this new, exciting, and very expensive non-statin territory.
Exactly. And these agents are strictly for those high-risk patients who are not at goal on statins.
Let's start with the PCSK9 monoclonal antibodies, evolocumab and alirocumab. The mechanism here is just so elegant.
It is. So think of the LDL receptor on your liver cell as a port that pulls cholesterol out of the blood. Well, there's a protein called PCSK9 that acts like a garbage collector. It binds to that receptor and tells the liver cell to destroy both itself and the receptor, so you lose your ports.
No ports, no unloading the cholesterol cargo.
Precisely. These monoclonal antibodies, they just block PCSK9. They preserve the receptors, which dramatically increases the liver's ability to clear LDL from the blood.
And the LDL reduction is massive, up to 71% with evolocumab. You see that number and you think, okay, problem solved. But what do the clinical outcome trials actually show?
And this is the critical paradox you have to remember. Despite that massive, almost unbelievable drop in LDL, the actual clinical benefit is categorized as only a small decrease in the risk of MI.
Just small.
Small. And this is the most important part. The trials showed these drugs did not result in a clinically meaningful difference in all-cause mortality, CV-related mortality, or stroke. And we have moderate certainty on that evidence.
Wait, how is that possible? If you drop the harmful particle by 70%, why isn't the benefit just as overwhelming?
That's a primary hypothesis.
Yeah.
We think maybe by the time a high-risk patient gets this drug, the inflammation and plaque are just too advanced. We're reducing the vandal, but the damage is done. And look, we have to talk about costs. These are complex injectable drugs, so AACE conditionally suggests them for ASCVD patients who aren't at goal. But they strongly suggest against using them for primary prevention in low-risk people. The cost-benefit ratio just collapses.
Okay, let's move to the drug that seems to solve the compliance problem, inclisiran. The mechanism here is even more futuristic.
It really is. If the monoclonal antibodies block the PCSK9 garbage truck that's already running, inclisiran stops the factory from ever building the truck. It's a small interfering RNA, in siRNA, that literally interferes with the genetic instructions, the messenger RNA needed to make the PCSK9 protein in the first place.
It's targeted gene silencing? That's incredible, and the dosing is the real revolution.
It's the ultimate compliance advantage. You get an injection, another at 3 months, and then only every 6 months after that.
For a patient who's facing a lifetime of daily pills, that's a game changer. So if compliance is solved, why isn't ACOE giving it a ringing endorsement? Why is this defense? No recommendation on hard outcomes like MI and stroke.
It comes back to certainty. The trials for inclisiran were just. They were pretty short, and they had a very low number of heart events, like death. The task force looked at the data we have right now and basically judged the desirable effects as trivial. So we have this huge benefit in compliance, but we don't have long-term certainty on outcomes. Plus, we can't ignore the high cost and the fact that it has to be given in a clinic, which immediately raises equity concerns about who can actually get it.
Right, revolutionary mechanism, but the data and accessibility are lagging way behind.
Hmm.
Okay, next up, Bempedoic Acid, the drug for statin-intolerant patients.
Bempedoic acid is so relevant because muscle pain from statins is a huge reason people stop taking them. BA works on an enzyme upstream from the statin target. But the molecular brilliance here is that BA is a prodrug. It's only activated by an enzyme found in the liver, not in muscle tissue.
So it gets a liver-only pass. It can't become active in the muscles and cause that pain.
Precisely. It lets us bypass that muscular side effect. And that's why AAC conditionally suggests its use for statin-intolerant adults with ASCVD or high risk.
But the sources stress this requires some really serious shared decision-making. We're trading one risk for a few others, aren't we?
That is the critical conversation you have to have with the patient. While BA offers a small reduction in MI, the data shows a moderate increase in people starting the drug due to side effects. About 21 more patients per 1,000 quit.
And what are those side effects? Because they sound pretty serious.
They can be. The specific risks you have to discuss are gout, cholelithiasis gallstones, and, yes, tendon rupture.
Wait, tendon rupture, so we're potentially trading chronic muscle soreness for an acute, maybe disabling structural injury?
You are, and that's the trade-off. When you sit down with a patient, you have to ask them, are you willing to risk that acute injury to avoid the chronic muscle soreness? That is not an easy question, but it has to be an informed one.
Let's shift gears to part 4, triglycerides, specifically for patients whose levels are between 150 and 499 who also have ASCVD risk.
Right, and here the landscape is very confusing, especially around fish oils. We can start with Icosapent Ethyl, or IPE. It's an EPA monotherapy. ACE suggests using it on top of a statin, but it's a conditional recommendation with low certainty evidence. It showed a small reduction in MI,
How small is small?
about 8 fewer heart attacks per 1,000 people. The trade-off, though, is that the trials also saw an increased risk of atrial fibrillation.
That's a significant risk for a pretty small benefit. What about the combinations, the EPA plus DHA that you see everywhere in supplements?
For those, the ACE judgment was that the balance did not favor their use. Combination fish oils showed no demonstrated decrease in the risk of all-cause mortality, CV death, MI, or stroke. And it's critical for you to remember, those non-prescription fish oil products are highly variable and not regulated like a prescription drug like ITE. Don't assume your over-the-counter pill is doing the same thing.
Okay. Finally, let's get the definitive verdict on niacin, vitamin B3. This drug has been around for decades.
And the ACE is firm. They strongly recommend against its use for hypertriglyceridemia. The reasoning is probably the clearest example of a poor risk-benefit profile in this entire guideline. The benefit is only a low certainty of a trivial decrease in MI. But critically, there is moderate certainty of a large increase in people quitting due to side effects.
So the side effects just overwhelm any tiny potential benefit.
They absolutely do. We're talking about 98 more discontinuations per 1,000 participants. The risks are hepatotoxicity, making diabetes or gout worse, and the increased risk of myopathy when you combine it with a statin. Given that, niacin should really be considered retired for this purpose.
So to synthesize this whole deep dive, it really seems like ACE is reinforcing that we need to prioritize known efficacy over, these new and exciting mechanisms.
Absolutely. The foundation is still lifestyle and a maximally tolerated statin. You notice almost every new, expensive non-statin recommendation we talked about is conditional. And that's because the evidence for hard long-term outcomes like mortality is still low or moderate. That skepticism is appropriate.
Which brings us to the non-negotiable step, shared decision-making.
It is essential. You have to discuss the benefits, which are often small for these non-statins, the high cost, and the very specific serious harms. That conversation has to cover the risk of AFib with IPE and, yes, the risk of tendon rupture with bempedoic acid. The patient has to understand the trade-offs.
And let's close with the really profound knowledge gaps that the AACE task force itself pointed out. Despite all this revolutionary science, some fundamental questions are still totally unanswered. You mentioned that acute pancreatitis risk early on for triglycerides over 500.
We still have insufficient data on whether any of these new agents, like IPE or even niacin, can actually prevent acute pancreatitis in those high-risk patients. These people are in a crisis, and we still lack high-certainty evidence for the best way to save them from that specific terrible outcome.
That's shocking, given how long we've known how severe that is.
It is, and what's more, we lack sufficient data on lipid management for other key high-risk groups, like patients with type 1 diabetes. So the question you should be mulling over is this. Why, despite all these cutting-edge tools and molecular breakthroughs, do these fundamental life and death knowledge gaps still persist in critical patient groups?